Hey everyone, welcome to the Being Patient podcast. I'm Deborah Kahn, founder of Being Patient. When my mom was diagnosed with Alzheimer's disease, I decided to use my skills as a journalist in a different way. Frustrated by the lack of information on science and the inability to get different expert opinions, I decided to quit my job at the Wall Street Journal to create a better platform for people impacted by dementia. We are a community where news and information is created by our team of journalists. We ask tough questions and we simplify the science so that anyone can understand. We don't only cover disease, but delve into the latest research on what it takes to keep our brains healthy. We invite the experts and ask your questions. Here's today's podcast. I hope you enjoy it. Hi, everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Well, today we're going to talk about palliative care in managing the care of dementia. It's a specialty of Erin Zahradnik. She's at the University of Chicago, and she's an assistant professor of psychiatry and behavioral neuroscience. Erin, thanks so much for joining us today.
I'm glad to be here. Thanks for having me.
So I think we have got us up. I have to be honest. I often thought of palliative care as really in the later stages. So how do we start? How do you define palliative care?
Definitely a good question. And it's confusing for a lot of people. So you can think of palliative care as kind of the umbrella term for essentially symptomatic management of patients who have any sort of really serious illness. It doesn't have to be a terminal illness. It could be something like a curable cancer. It could be something that has no cure, like dementia. And it's really, it kind of varies as to what it includes, but essentially it's supportive of the patient and of the family. It can be medication support. It could be psychological support. It could just be someone to kind of help you make those decisions that have to be made if you're going through a serious illness. And then there are different aspects of palliative care. So hospice, which is really the end of life, is just a part of palliative care. And so that's a very specialized version of it. And it involves kind of changing your insurance benefits and very specific care that you're allowed. It involves kind of having a whole team. And it's really for people who are at the end of life, so traditionally 6 months or less. But palliative care in general can be for anyone.
So it's really a management system. It's a plan on like really all aspects, right, of care. I mean, and I love this because as somebody who has a loved one with dementia, that's so badly needed at no matter what stage you're at. So let's kind of walk me through it in a timely fashion, so to speak. In the beginning, I assume in an earlier stage, you are speaking directly to people who have been diagnosed with dementia. Am I right about that?
Most of the time, yes.
So what are some of the issues at that early stage that often come up that you need to pay attention to in order to get a plan in place?
So the biggest thing is probably thinking about practical matters like who is your power of attorney or your healthcare decision maker. The term varies depending on what state you're in. And do you have that in place? Do you have the paperwork? Have you talked to the person and let them know that they are in fact your power of attorney? And have you discussed end of life decisions that you want made? So this can be really important to do early on when a patient has more awareness and is able to make their own decisions and really explain what's going on and to engage in conversations with family members. So a lot of times people are really reluctant to do this, especially with dementia, because we don't think about dementia necessarily as a terminal illness. It's like a memory problem, but it really is a terminal illness. Um, and
So
so
what do you
it's,
tell
Mhm.
what do you tell your patient or your patients at that point? I mean, at that very beginning stage, um, what do you how do you equip them with the plan to, like you said, this is a long-term illness.
Mhm.
This is really coming up with the playbook through the course of many changes.
Mhm. So in steps, small steps, we have time with dementia. It's not a quick moving disease for the most part. It's very slow, and you don't want to overwhelm people. Just hearing that you have a diagnosis of dementia can be pretty shocking sometimes to people. Sometimes not to the patient, depending on how far along they are, but definitely can be to the family member just to hear those words, especially if you hear the words Alzheimer's, because it's kind of notorious. So just, letting them get used to that idea first, and then step by step, deciding, okay, should we talk about who's going to be your decision maker now? Should we talk about what things look like as the disease progresses? Where's the patient and the family with their understanding of what's going on, and are they ready to talk about it yet?
I mean, I would imagine a lot of people seek palliative care when they're in a state of crisis. I mean, that's really when you kind of look for quick solutions. Do you find that maybe you're seeing people when more behavioral issues are coming up, because that's almost when you reach the point of crisis management?
Yes, I would say 100%. Well, maybe I'll say like 98%. The people that I see with dementia, whether it's early or late stage, it's because there is some sort of symptom going on. Especially later stage, patient and family are really suffering and they need someone to talk to about it.
So, what are I imagine things like behavioral changes, outbursts, hallucinations. What does
Mhm.
that look like when you turn to palliative care?
It's really the same concept. Ultimately, there's not a ton of difference from the approach that I would take if I was doing just palliative care or if I was doing just geriatric psychiatry. I mean, it's hard for me to separate because I do both of them together, but it's really the same approach. You're just trying to help the family um, find out what their goals are for the patient, and what you can help most with. And that's sometimes medication, and it's sometimes working without medication. It really depends on what they're interested in.
So, I guess this is it's tricky to generalize, but we often get this question on being patient, which is when do you know it's the right time to turn to medication?
Well, it depends on what medication. So there are, um, and it depends what symptom you're having. If you're coming and you're feeling like you're just really anxious or really depressed, and it's pretty early stages, then you can go on traditional antidepressants if that's something that you're interested in. I think when we're talking about really medication and dementia, most of the time it's the stronger drugs, the antipsychotic medication, when people start to have a lot of paranoia and delusions and that kind of a thing. And really, the starting point is when things are becoming dangerous for the patient or the caregiver. And so it can be, somebody's in physical danger because the patient's combative. It could be that the patient really keeps wandering out of the house, and you've tried all these different techniques to try and get that to stop. The patient keeps calling the police. That's really common, actually, and saying, there's an intruder in my house, and then they come and it's actually their wife. And once when police get involved, that's a big sign too. We don't want that to continue.
I mean, one of the things that strikes me too about dementia is I have a parent with Alzheimer's. I have many friends who also have parents with dementia, the symptoms are strikingly the same, right? What you just mentioned, like someone's come in and is stealing my stuff, or getting confused, that people are coming into the house and taking my things, and do we know why why inside the brain does this happen, this paranoia happen? Do we know which part of the brain it impacts in order to kind of create these very similar behavioral reactions?
We don't, at least that I know of. And I've always been curious about that too, because, you're right. It's the same. I can list off the delusions and people are just nodding and saying, oh, yes, yes, yeah. Yesterday, my mom insisted that she was, in her own childhood home and that they were, waiting for their dad to come home. And I just didn't know what to do. And she thought I was her mother. And people coming in and stealing things. It's so common, and they're really similar. But
so to
sure.
ask, to ask the psychiatrist side of you, if we're talking about non-medications, what's the strategy we should all be employing to really avert crisis?
Really, it's just behavioral modifications and making sure that families really understand what dementia is and what the behaviors are and how to interact with the person. That's probably the best intervention, better than medication and all of that.
So for example, your loved one is having an outburst saying someone's come in and stolen everything, and the worst thing you could possibly do is say, no, they haven't, right? Is that right? Or
yes.
So what should we be saying?
Yes, the best thing, if they're saying something like that, or, anything that doesn't quite make sense, is just to go with it. Just to go along with it and maybe change the subject pretty quickly so you don't get entangled in it. Yep, I'm sorry, we're going to look into that. The locksmith is coming tomorrow to check on that. We've got cameras installed. What do you want for dinner tonight? Just going along with it. There's no way you're ever going to convince somebody that their delusion is not true. That's in general, and certainly not when it's coming from a dementia. It's just going to cause a lot of agitation and fight. So I say just go with it. It's okay.
So, but how do you deal with the anger? What if the person is really angry and combative and starts to kind of take a swing at you, which we hear all the time? That's quite a normal stage. When somebody is in, a really angry state, somebody who's never heard a fly before will swat the caregiver, what do you do then?
Well, I mean, the best thing is not to try and avert those instances from getting to that point. But if, it's happened, you just think that the person is reacting that way because they're scared, because their brain is confused, that they don't understand what's going on, they don't understand who you are, and they're just reacting kind of instinctually, like a little kid would do if they were approached by a stranger that was trying to grab at them. They're scared, and so how would you treat a scared stranger that was lost? You'd kind of keep your voice low, kind of talk in a calming tone, back away a little bit. If the patient is safe, you can kind of step out of the room. If they're trying to fall out of their wheelchair or something, then that's a little iffy, but back away, talk softly, maybe put on some soothing music. Really try not to engage with the anger, just kind of project the calm, because people pick up on your emotions too.
Yeah.
And so if you're just thinking calm thoughts, even if you're also really stressed, you're just thinking nice, calm beach day, pushing that out towards them, that can be really helpful for calming the situation.
Well, and they always say, like, people with dementia can feel, right? They might not remember, but they can still feel emotion. And so,
yes.
Yeah, separating that. So I want to ask you another question about the medications, because we get a lot of questions about medications, and mainly that, there's a lot of, you mentioned antipsychotics before. There's a lot of different antipsychotics on the market. we have people who have written in and said, they've tried many different combinations, ones like, how should we look at that? I mean, if it comes to actually having to consult your doctor, which a person would do in order to, I mean, we hear you never know how the person is going to react to a certain medication. So in a way, it's kind of like trial and error. Is there a better way to do it? I mean, because some people, the medication works really well. Other people, they have to change their medicine 4 or 5 times before they find something. And some people never find the right combination. So why is that?
Well, it's hard to say. I mean, those are antipsychotic medications, and they're for treating schizophrenia. And even though you have delusions and paranoia and schizophrenia, it's not the same thing as these delusions and paranoia and dementia. So we're kind of throwing these medications at somebody and hoping that, a few of the receptors they stick to are going to be the ones that help this person. But we don't really know. And that's why you get such varied responses. A lot of geriatric psychiatrists kind of have their own regimen. They have their favorite medications they use. I have a couple that I use. There's one I use, another I use, and then, then we move on to something else. And it depends on their experience.
So as a side, I mean, we hear a lot of complaints that sometimes these antipsychotics or antidepressants make the person not almost like they're in a comatose state, right? Just like quiet and almost zombie-like. And that's almost equally as hard, right? I mean, it's probably a little bit easier to manage than the combativeness, but at the same time, if your mom's no longer seems like your mom in personality at all, then that's a really hard thing to take. So what do you say as a doctor? Like, how should people, how do you know in terms of psychiatry and palliative care being coming up with the management of all of this, how does one know what the right balance is?
Well, so that's actually straight from palliative care. And that involves having a goals of care conversation with the family, which is, here's the medications that are traditionally used. Are you, what's important to you? What's important to your mother? Is the goal for, your mother to be calm no matter what? Is the goal for her to be awake and, as calm as we can get her, but primarily awake? What is the thought process there? And people have different ideas, and that can help you figure out, maybe what medication you're going to go with, or how often you're going to give it, or what dose you're going to use, or even if you're going to use that kind of medication.
So, Erin, is there, when you kind of look at the range of your practice, can you give us sum it up about just things that we really need to think about as we move through this journey? I mean, like we talked about in the beginning, old needs are replaced by new needs. You're kind of moving through different stages. Old problems are replaced by new problems. It's certainly a test of resiliency. But what do you say to your patients? I mean, both caregivers and people with dementia. What is the key to really managing all of this?
The key is really support. The patients are usually aware, well, not always, but sometimes they're aware for a time, but that generally goes away. So the burden lies on the caregivers, and support is so, so important. Earlier the better. I mean, just even if it's an online group, if it's just reading a book or an article about something, watching a video, anything where you can look at it and you're definitely going to say, oh, they get it. That sounds familiar. That's what I'm going through. Just that sense of I'm not alone and I'm not isolated is really important, because, if you as a caregiver are really stressed, then, the patient's going to be stressed. I mean, it's important to take care of yourself.
Yeah, absolutely. We have a question coming in from someone saying, what resources should people start looking into after they or a loved one received a diagnosis? That is after they go to beingpatient.com, but I'll leave that to you.
So it depends where you are. I mean, one of the places that I work at University of Chicago is a geriatric medicine clinic, and so it's kind of integrated. There's me, the psychiatrist, there's the geriatricians, there's social workers. So we have kind of internal resources there. In general, I direct people to the Alzheimer's Foundation, even if they don't have Alzheimer's, if they have any kind of dementia, just because they have so many resources and branches in so many places.
Yeah, and one of the things that we're trying to do at Being Patient is give people access to people like yourself, so that when they have these questions, you have access. I mean, we hear a lot. The problem with caring of someone with dementia is you see your doctor maybe once every 6 months, and a lot of questions come up, as we know, in the between those appointments. So I think it's really helpful to have a coordinated plan, as you mentioned. Do you have any place where people can go to that you publish your geriatric research, or is there a site at University of Chicago?
We have our department website, which is a little bit under construction right now.
Okay.
So there's not a lot to find there, but I think really through University of Chicago geriatric medicine is really where you would find the most resources.
Okay, and we can post the link in this Facebook chat. So thank you so much, Erin, for your time. I know it's a badly needed service for many people. So we appreciate your focus on geriatrics and psychiatry, palliative care. Excuse me. To our audience, we continually publish these interviews. We'll upload them on our site on beingpatient.com. If you have a suggestion for an expert you would like us to approach, or a topic, please, by all means, email us at info@beingpatient.com. Thanks very much for watching. If you missed any of this interview, head over to beingpatient.com and sign up for our newsletter for news of upcoming talks. Thanks very much for watching. Well, I hope you enjoyed today's podcast. For more information on upcoming interviews, don't forget to sign up for our newsletter at beingpatient.com. That's beingpatient.com. And send us any feedback you may have, whether it's someone you want us to interview or any comment about our podcast series. You can do so by emailing info@beingpatient.com. Thanks for listening, everyone. I'm Deborah Kahn.